So, okay, yeah. I'm just going to move. This is just move the slide. No. How do I move slides? All right. That's okay. I can look at that. Yeah, that's okay. Yeah, as long as that's hi everyone. Good afternoon. Thank you for the invitation, and I'm really happy to be here. So, my research talk. Usually, my research talk is more like for the people who are in my research field. So to prepare for this talk, so I decided to do a little bit more kind of high level thing to look at what the machine learning has been used in clinical cancer care, actually has been kind of practiced, let's say, more not on the research front, but more kind of in the clinical front on that field, as well as some of the sample research that I have done in that area. So to begin, I looked into, what is artificial intelligence and what is machine learning, these kind of definitions up. As far as I can tell from the samples I gathered, as well as my own work, we are squarely in this machine learning field, which is a subfield of the artificial intelligence. Okay, and we are mostly like a supervised, unsupervised, as well as reinforcement learning. So I started the research by looking at this book published by American Association for Cancer Research. They had this landmark achievement in cancer research from 1907 to 2022. So the latest edition in the last 115 years. So the first thing that related to machine learning is this paper published in 2017 in Nature. It's about visualizing dermatologist level classification of skin cancer with deep neural networks, which I'm happy that our previous speaker just actually explained what is deep neural network. So essentially, these are the cancer, like 3 cancer types. And then the other 2 are non-benign skin conditions image. Okay, so these are essentially they're using the deep neural network to do image analysis of the skin. And this graph, it's from that paper, okay, from that 2017 paper. It's showing you T-distributed stochastic. NE is I think nearest neighbor embedding, kind of that TSNE. Basically, a way of super visualization of the last hidden layer representation in the CNN represented this convolutional neural network for the 4 disease classes. So this is a kind of a 2-dimension visualization of this complicated black box neural network that used to do this classification work. All right, so then there's actually a lot of applications in radiology in the AI field. This one is the first FDA clearance cover for this Artersy, I can't pronounce that. This software company, let's say, covers all solid tumors that it initially, this radiology aid launch will include the liver AI and the lung AI oncology softwares that is aimed to empower clinicians to quickly measure and track lesions and modules in MRI and CT scans. I think one of the important achievement here is not only FDA clearance, but also it can track lesions over time. So that's one major, I think, advancement there. And that was a 2018 news, so fairly recent. And this paper I put is again, 2018 paper. So basically they looked using machine learning models to predict pathological upgrade and reduce unnecessary surgical excisions in breast lesions. I put it here in radiology component because it's published in the radiology journal, but actually when I read it, it's not necessarily radiology because it said they're using features such as age and HRL, high risk breast lesion histology results used in the model, as well as text features from the biopsy pathology reports. So essentially it's just machine learning classification model. I don't know exactly what to do with radiology. I suppose because it's a breast lesion started from the radiology aspect. And they found that if those categorized with the model to be at low risk for upgrade were surveilled and the remainders were exercised, then 97% of malignancies would be diagnosed at surgery. And then only 30% of surgery of benign lesions could be avoided. So basically you're treating one malignancy get missed with saved 91 surgeries that you don't need the unnecessary surgery. All right, this is a 2019 paper. Sorry, it's been cut off there. It's 2019 paper in Lancet. A review of comparison of deep learning performance against healthcare professionals in detecting disease from medical imaging. It's a meta-analysis, and they found in 2019, they found 25 studies with external validation, where okay, so these 25 studies, they are not only including cancer, but also other diseases. So I'm just to kind of pull the cancer studies here because that's where my work has been focused on. So 3 on breast cancer, 3 on dermatology cancer, 2 on lung cancer, and 1 each for the other few types of cancer. And they concluded that based on these 25 studies that have external validation, the diagnostic performance of deep learning models is to be equivalent to that of healthcare professionals. Of course, we have to be aware of maybe the publication biases, but this is what the best out there in the literature. All right, I noticed in our agenda, actually this morning there's a neuropathologist talk, which I missed. So I don't know if the neuropathologists have already talked about that or not. No? Okay, so this is a 2018 paper in Nature published on the DNA methylation-based classification of central nervous system tumors, so brain tumors, essentially, mostly of them. And this has quite influential in the sense of the 2021 WHO tumor classification for the CNS has already incorporated some of it. This is research, right? So, but some of it has already been incorporated, especially for pediatric CNS tumors in the WHO tumor classification. This is again, the same unsupervised visualization dimension reduction of using this TSNE method, the same one that we have looked at in the dermatology pictures of these different about 1991 classes of CNS tumor, and they visualized it on a 2-dimension space, and different colors represent different type of CNS tumors, which is very complex. All right, so I guess I'm going to take a break and switch to what have my own involvement in the health research and machine learning. So my formal education, I had a bachelor degree in biochemistry and then followed by a master degree in animal behavior. Afterwards, I got my degree in biostatistics, which is a master degree where I studied the classification and the regression tree with application to drug discovery. So this classification regression tree is really a type of early models of machine learning type of thing, statistical learning thing. And when I did my PhD, my focus has been assessment of algorithm performance for event time prediction, which is like survival time, time to event time of thing, but how do you assess them basically? And in my work, I first started in Alberta Cancer Board for a couple of years, and I moved to Alberta, Alberta. And the three work I highlighted here are kind of related to the machine learning. So relatively like relationship between algorithm performance risks, metrics, and then the risk prediction of cancer treatment related late effects for childhood cancer survivors. And the last one is this developing natural language processing based algorithm to extract cancer mass diagnosis from radiology pathology reports for the cancer registry. So these two sampled applied research project, I'm just going to talk about is the last two that I just mentioned. So yeah, okay, so I have worked on this for about the last 6 years. Okay, so cancer, childhood cancer, there's like 85% survival rate now, like after in 5 years. So there's a lot of childhood cancer survivors, but they're facing a lot of late effects. One of the late effects is this for the female is a premature menopause, which in clinical definition they call it primary ovarian insufficiency, which is shorthanded by POI. It basically means a compromised ovarian function before age 40. And the prevalence in general population is about 1%, but in the cancer survivor is about 15%. So it is going to be very useful from the clinician's point of view to consult the patient if they have higher risk or lower risk of this particular fatality implications of the cancer treatment. And this graph just shows the decline of ovarian reserve as a human female age. And when you hit a threshold of follicles, then you hit menopause. And at a certain cancer therapy can accelerate this decline. And these are some known risk factors, and these are actually being, it's in the guidelines, long-term follow-up guideline for survival of childhood provided by the Children's Oncology Group. So radiation, the pelvis region radiation, total body radiation, and chemotherapy. There's many different classes of drugs that can influence their ovarian function. So we have developed and validated a prediction model for one thing is called acute ovarian failure, which is basically the ovarian hit the menopause within 5 years of the cancer treatment. Okay, so it's a subtype of the POI, and this has been published 2020, and we had a web-based risk calculator out there. And we also, the current work, which I'm going to just mention briefly here, is the age-specific POI, which is, we finished the writing, it's just going to be circulated among our co-authors, and we will submit it hopefully in the next couple of months. This is kind of how we approach this work. Okay, so we started with the data is coming from this childhood cancer survivor study with 11,000 patient data. And we have exclusion criteria. After all the exclusion, we have a final sample of 7,000-ish, 8,000-ish female survivors contributed to this study. And then in addition, we also have genetic contributions to genetic information on about 2,000 patients, survivors, which we did also investigated the genetic contributions to the clinical risk prediction model that we developed. And this is just a quick overview of what the process looks like. First, you merge and clean the data, clean data with missing values. There's about 90% of observations record survivors, they don't have complete record on every single variables we collect. So we have, if you remove all of them, there's two problems with that. One is can introduce bias, the other you're reducing a lot of, sample size is important, right? So we used the way that we deal with the missing data is using imputed data. After that, we also have to deal with sensory because, it's a longitudinal follow-up. People are being, maybe at age 34, we know their status, but then they're only hit age 34 yet. We don't know what their status is going to be afterwards, right? Especially for those who are normal. If they're not normal, obviously the POI already, then their status is fixed. So we have to deal with this using a technique called inverse probability sensory weighting. After that, we develop the models, and then we evaluate the performance and then validate the performance in external cohort. So these are the 4 models we actually investigated. The last one being the machine learning model. Okay, it's called XGBoost. It's based on the gradient boosting framework, which allows complex interactions between different predictors, risk factors in the model, in the data set. And the first one is a very traditional approach to a time to event analysis, which is a Cox proportional hazard regression. And then the second and third, they're both logistic regression, but one is being a modified logistic regression for the prediction performances, let's say. So we just looked at all of that, and we looked at performance metrics. These 4 metrics has been utilized. In the previous talk, we heard about the AU-ROC, which is the ROC thing right on top. But we also have like calibration as well, overall performance, as well as these like positive predictive values, like threshold-free metric. All right, so this is on the internal validation, which is like on the internal data, on the development cohort data. We first looked at how they perform. These are 4 different metrics, and then these are the 4 different letters basically tell you 4 different methodology algorithms that we employed. And we see that the age-specific XGBoost and the logistic regression, they will outperform the Cox PH, which is not something surprising. But surprisingly, we also find that the logistic regression outperform the elastic net logistic regression model, which is supposed to improve the prediction modeling. So we send the XGBoost, which is a black box model, machine learning model, and then the logistic regression for the external validation. So this is our external validation data set. It is a Sanju Life cohort of participants. We had about 2,500 patient survivors there. After exclusion, we have 1,300 patients with 100 POI cases observed. And one thing different between this cohort and our previous cohort is the previous cohort, the POI status is based on self-reported questionnaires, while this one is a clinically ascertained POI status with measurement on their hormones as well as their menstrual status. And these are the performance comparison I'm showing you here. One is on the development cohort and the other is on the validation cohort. They're on the same scale. So you can see that on the validation cohort, our algorithm, which here is really logistic regression, okay? Logistic regression outperform on the development cohort, and they are on all measures, on scaled barrier score, on the ROC, and then on the PRC as well. And then there is if you okay. All right. If you know any elementary statistics college level, this Z is a standard normal distribution. Okay, so the Z 0 means like perfect normal. Okay, and then if you have something on the validation set, it's about like -4. So it sounds like pretty bad, right? So we did look at certain, we did look at, we are just kind of picking a few ages. For example, this is age 26. We looked at the calibration curve, actually, the predicted versus observed, and then plotted it, the calibration curve, and looks, if it's along the diagonal line, that means perfect calibration. This is not perfect, but we think this is reasonable and it's acceptable. Okay. So again, here we have two colors. We have both the XGBoost and logistic regression. You may ask me, why don't you use the XGBoost? The reason being, on this validation model, the XGBoost and the logistic, they perform similar. Their performance is similar to the extent that we don't think the XGBoost will warrant the clinicians like they would prefer logistic regression because it's more explainable and very easy to understand, while also as well as computationally more friendly. When I say computation more friendly, is these are my website for these two calculators, one for AOF, one for the POI. If you scan it, you will see it. The POI calculator, if we do logistic, it's quick. It's like a run right away. But if we run the XGBoost on the public server, it takes 1 minute to calculate, so which is unacceptable, too slow. So that's why another reason we did not put it up there. And then I just want to acknowledge the CIHR for the funding, as well as my close collaborators. Those are the PIs, have pictures, and the trainees, I only have names here. Sorry for that. And I do acknowledge other funders for this work. And then I'm just going to, like, my current ongoing work is this cancer registry and the cancer metastasis. So cancer progression, recurrence, and the metastasis are clinically important and critical to the treatment. But population-based Canadian Cancer Registry, they formed in 1969 to capture these incident cancer cases. Until this day, the registry don't have the mandate. They don't have the capacity to capture the cancer progression information. They don't have the metastasis information post their primary cancer diagnosis. The patient survival was actually captured via passive linkage with the stats, vital statistics database. So there is a disconnection between the high quality population cancer data and the clinical research and surveillance needs. So we want to address this by looking at developing a natural language algorithm that capture these brain mets. That's our first step from radiology reports, and capture molecular marker data elements from the pathology reports for the cancer registries. Right now, we are partnered with Alberta, British Columbia, and Ontario registry, and the clinicians in these provinces. So with that, I'd like to just close it, and any questions? I convinced everyone. Convinced everyone for you need machine learning tools in the cancer research. Yeah, we need more.
Thank you very much. A huge round of applause, please.